This podcast is being recorded on the lands of the Wurundjeri and the Bunurong people of the Kulin Nation. We pay our respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders, past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we will use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest clinical guidelines and research in obstetrics and gynaecology through conversations with leading experts. On today's episode, we're focusing on gynecologists' role in prevention of vulval squamous cell carcinoma by identifying and treating vulval intraepithelial neoplasia, or VIN, and distinguishing these from benign squamous intraepithelial lesions. I'm your host, Dr Anna Clare, a general gynecologist based in Perth with an interest in vulval health. And joining me today is Conjoint Associate Professor Tania Day. Tania, welcome. Would you like to tell me a little bit more about yourself?
I'm Dr. Tania Day. I'm an academic gynecologist and vulval specialist in Newcastle, New South Wales. And as part of the ISSVD VIN Terminology Committee, I was the lead author on this update. And the work arose out of 10 years of research with Prof Jim Scurry on the clinicopathologic diagnosis of vulval dermatoses and cancer precursors.
And before we get going, can you just let us know if you've got any conflicts of interest?
I have none.
Okay, I think a lot of us who have an interest in vulval disease would be quite jealous of having a great pathologist like Jim Scurry in Newcastle.
Fabulous.
Yeah. And pathologists have always looked to the WHO about the naming and diagnosis of VIN and SIL, whereas clinical guidelines has been provided by the ISSVD with the last terminology published in 2015. An update has just landed. Why did this need to be updated?
Since 2015, there's been a major advancement in our understanding of VIN histopathology and immunohistochemistry, establishing that the correct etiologic classification predicts outcomes. And as a result, it should influence our treatment and surveillance.
So what's the difference in the new terminology?
We highlight in the document a couple of overarching principles that are new to the 2026 terminology. And the first is that VIN and SIL are classified by etiology, distinguishing HPV-associated, or HPV-A, from HPV-independent, or HPV-I, disease. The words neoplasia and lesion denote biologic behavior. So squamous lesions are epithelial abnormalities not otherwise specified, whereas squamous neoplasia refers to epithelium that has the potential to progress to cancer. P53 and P16 immunohistochemistry are essential tools for accurate classification and risk stratification. And the paper has a dedicated table that explains and defines the P16 and P53 staining patterns. Finally, when there's a discrepancy between the clinical impression and the histopathology report, that should prompt direct communication between the clinician and the pathologist.
So let's go through it section by section. Starting with HPV-A disease, what's the preferred terminology for precursors to SCC that arise from persistent oncogenic HPV?
The new preferred term is HPV-A VIN. It's also acceptable to use HSIL, or high-grade squamous intraepithelial lesion, when referring to analogous lesions at the cervix, vagina, and anus, and in communication with colposcopists and cytopathologists.
So no more usual VIN. I did find that trainees and colleagues often weren't sure what the U stood for.
The U was confusing, so we abandoned it. So terms that are not recommended are usual VIN, classic VIN, VIN 2-3, severe dysplasia, carcinoma in situ, Bowen's disease, and Bowen's papillomatosis.
I think most gynecologists have some experience with HPV-A VIN. Sometimes you detect it incidentally, but women often present with itch or pain or rash or a lump. Exam features can be variable, so a white, grey, a pink, red, brown or pigmented papules or plaques, shiny, smooth red macules, and multicoloured verruciform plaques. And there's an overlap with condylomas. The application of acetic acid is not required to identify HPV-A VIN, but it can highlight subtle disease, but pigmented areas are often unaltered. What should clinicians know about the histopathology of HPV-A-VIN?
The histopathology shows nuclear atypia seen as basaloid cells that comprise at least 1/3 of the epithelium. These round cells stain dark blue because of their big hyperchromatic nuclei. And when maturation of the epithelium is partially retained, you see HPV cytopathy in the mid to upper epithelium. So these are coilocytes, and those show perinuclear halos and sometimes multinucleation or atypical mitoses. There is a positive, block positive P16 and a wild type P53.
Mm-hmm. And I guess it might be useful to point out at this time that when we talk about P16, that's immunohistochemistry, and that is unrelated to the HPV-16 high-risk HPV that you might get on a CST. One reason it's helpful to establish the diagnosis of HPV-A-VIN is that it has several treatment options. How do you approach management?
The treatment options are topical immune modulators, ablation, so I use laser, but there's other forms of ablation, or excision. Imiquimod is a great option for those who've had cancer excluded. It's effective, and it avoids surgical morbidity and anatomic alteration. The medication is applied 3 times a week for 16 weeks, and I usually follow up patients at 2 months to see if they've been able to persist with the medication and to check for their response. Laser is a fantastic option, again, if you've excluded cancer and you have it in your center. It's great for sensitive sites like the periclitoris and the perianus, for hairless skin, and for patients who you anticipate may need multiple treatments over the course of a lifetime. Excision has the highest short-term success rate, but we think that overall your long-term recurrence rate is unrelated to treatment modality. It's the best option for hair-bearing skin, particularly when tissue redundancy means that you can achieve a tension-free closure. And the ISSVD offers some flaps and graft courses for those who might wish to add that to their surgical practice.
And as you say, recurrence is really common, with at least 40% and perhaps up to 60% recurrence during a lifetime, with a 10-year progression risk for HPV-A-VIN is about 8% to squamous cell cancer. How do you follow up these patients?
HPV-A-VIN does require long-term lower genital tract surveillance to both detect and treat recurrence. But the optimal duration, content, and timing of this surveillance remains unclear. A common protocol is a 6-monthly examination of the vulva, accompanied by annual inspection of the vagina, cervix if present, and some form of anal screening, and that could be a digital-anal rectal examination or cytology or HPV, depending on what's available in your area. A positive cervicovaginal oncogenic HPV result does not predict HPV-A-VIN recurrence, but it does suggest there's an increased risk of vaginal HSIL.
The 2026 Asia Oceanic Congress is being hosted by RANZCOG in Sydney from 12th to 15th of October. The theme, Equivolution, will cover topics such as sustainability and equitable healthcare for women of all backgrounds. This is your chance to be part of our region's largest O&G event in decades. Meet international experts and hear about innovative research. And of course, take the opportunity to enjoy Sydney's stunning nature, food and culture. Early bird registration closes soon on 30th of June, so be sure to book your spot today for the best prices. Visit AOFOG2026.com to learn more.
As well as neoplasia, the terminology has also defined HPV-A lesions. What are those terms?
The 2 types of HPV-A lesions are LSIL, so low-grade squamous intraepithelial lesion, and condyloma. Both oncogenic and non-oncogenic HPV types can cause vulval LSIL and condyloma, but these lesions represent transient infections, so do not usually progress to neoplasia. Regardless of the current lesional diagnosis, positive oncogenic HPV confers a lifelong risk of HPV-A neoplasia. We outlined some terms that are not recommended for HPV-A lesions, and these include VIN1, flat condyloma, flat wart, and benign dysplasia. The word dysplasia really is scientifically outdated despite its common usage.
Yeah. Condyloma are familiar to most gynecologists, although perhaps less so amongst our junior colleagues because of the fantastic outcomes for the universal school-based gender-neutral HPV vaccination. Condylomas can be asymptomatic, but they can present with itch or discomfort or sexual problems if they're large with a mass effect, or hygiene difficulties if there's perianal condyloma. They can be small or bulky, pedunculated or sessile, and colour-wise can be sort of grey or white or pink or brown with similar pigmentation to surrounding skin or a little bit darker sometimes. How does this differ from vulval LSIL?
Vulval LSIL is usually asymptomatic and an incidental finding when we're undertaking surveillance for another condition, for example, lichen sclerosis or HPVA neoplasia, or if we're doing colposcopy for an abnormal CST. And LSIL appears as a gray, white, pink, or brown area, generally quite subtle, but can be made more evident with acetic acid. The appearance is not very worrying, but because you're often seeing it in someone with lichen sclerosis or previous HPVA neoplasia, you're likely to biopsy.
Yes, I have a low threshold to biopsy any new or changing abnormality within that clinical setting. So having outlined the differences clinically, what are the differences between them on biopsy?
LSIL has a smooth and flat or mildly undulating surface, mildly abnormal basal nuclei, HPV cytopathy, and the P16 may be negative or block positive. Condyloma, in contrast, has a bumpy surface and is usually thickened. The basal nuclei are variable. There's still the HPV cytopathy, and the P16 is almost always negative, but like everything in biology, there's exceptions, so it rarely can be block positive.
And this diagnosis is mostly about excluding neoplasia and providing reassurance. Spontaneous regression is common, so the lesions don't necessarily require treatment if you're asymptomatic. Treatment options would be topical destructive agents like podophyllin toxin or triclocetic acid, topical immunomodulators like imicrimod, or cryotherapy, ablation, or sometimes even excision. And perhaps let's move on now to the biggest change in this terminology. There's a new name for those SCC precursors that are not related to HPV.
Yes, the preferred term is now HPV-I-VIN, and this can be subcategorized into P53 mutant and P53 wild type.
That's great, there's no more DVIN. The word differentiated was confusing and wasn't really a reflection of the disease biology or the prognosis. What other terms for HPV-I disease were abandoned within the new terminology?
So we do not recommend simplex type VIN, carcinoma in situ, VOD, DEVIL, verruciform lichen simplex chronicus, and squamous cell hyperplasia.
So how should clinicians recognize HPV-I VIN?
Nearly all HPV-I VIN arises in lichen sclerosis, usually long-standing and inadequately controlled disease. Rarely it can occur in hidradenitis suppurativa and in patients with Fanconi anemia, but these patients, like anyone else, can develop HPV-A VIN as well. There's no convincing evidence yet that HPV-I VIN arises from erosive lichen planus. The mean age at diagnosis of HPV-I VIN is 70, but it is possible to have cancers and precursors during the reproductive age because the onset of lichen sclerosis can be in childhood. Itch and pain are common to lichen sclerosis and HPV-I VIN, but in both, around 10% of patients are asymptomatic. HPV-I VIN appears as white or pink-red plaques or shiny red macules, and these are distinct from the background abnormal skin. The surface features may be smooth, irregular, or mosaic. And any new, changing, or treatment-resistant gray, white, pink, red, or pigmented abnormality warrants consideration of biopsy.
I think it's also useful to mention again that acetic acid is not helpful to detect HPV-I VIN and is painful and unpleasant for patients. What do clinicians need to know about the histopathology of HPV-I VIN?
The major histopathologic advance this past decade was the recognition of the varied appearance of HPV-I VIN. So it can be keratinizing, which is just another word for differentiated, but it can also be basiloid or intermediate. And the morphology of HPV-I VIN can be thinned or thickened. It can be acantholytic or subtle. The diagnostic criteria for HPV-I VIN are atypical nuclei at the basal layer, but these may extend upwards into the mid and upper epithelium. The P16 is negative, and the P53 is supportive, and this is divided into the mutant and wild type categories. Patterns that are consistent with a mutant type are null, overexpressed, and cytoplasmic.
And I think for clinicians, we don't often talk about immunohistochemistry, but it really is important within this disease to differentiate between P53 mutant and the P53 wild type, because there's a prognostic difference between them. So the P53 mutant type HPV-VIN has more than double the SCC risk compared to the P53 wild type. But bear in mind that the wild type still carries about a 28% 10-year SCC progression rate, so still pretty serious. What has replaced the whole array of terms like devil and VAD and VAM?
This has been an area of controversy and non-alignment between the WHO and the ISSVD, but thankfully the research has progressed enough that we can resolve the conflict. Verrucous VIN is the new term to replace devil and VAD. This is the precursor of verrucous carcinoma, and it's a subcategory of P53 wild-type HPV-VIN. So verrucous VIN is exophytic with a rough and bumpy surface, and on histopathology, as one would expect, it's very thick and has upwards papillary projections. The basal nuclei are less atypical than they are in other types of HPV-VIN. Our terminology keeps vulvar aberrant maturation, or VAM, as an HPV-I lesion, and this exists on a clinical pathologic spectrum with lichenified lichen sclerosis. So VAM is a great term for pathologists because it allows them to express uncertainty about neoplastic potential when they're assessing a biopsy that is suspicious for but doesn't quite meet criteria for HPV-VIN.
So when we think about HPV-I and verrucous VIN, the names have changed, but the treatment and follow-up remains the same. It's excision. There's no evidence supporting topical immunomodulation or ablation as definitive treatments in this group. And patients with HPV-I precursors require lifelong maintenance with topical steroid regimen, titrated to achieve the objective LS control, defined as normal or near normal colour and texture. This could require the involvement of a gynaecologist, dermatologist, sexual health physicians, or other skilled practitioners with an interest in genital skin disease who provide long-term specialist-led surveillance. I did quite like the VAM as a term. I'm pleased it stayed. How is the management of VAM different?
The diagnosis of VAM should provoke a change in management using a process of shared decision-making with short interval follow-up to ensure resolution of the lesion. So factors we should consider include the duration and potency of the topical steroids, the suitability for and response to intralesional steroids, the lesion size and location, the patient's fitness for surgery, and the vulval anatomy. For some patients, it's appropriate to increase the frequency or the potency of the steroid, or to do that intradermal injection of betamethasone acetate or triamcinolone acetate. For some clinicians experienced in vulvovaginal disease, they may opt to do oral or topical retinoids or laser to reduce the lesional hyperkeratosis, which might improve the penetration of the steroid. But areas of concern that do not resolve with this optimized medical management should be excised as a diagnostic and treatment modality.
Well, I think this is a comprehensive summary, and my impression is the new terminology is simpler and it's easier to remember. There are no funny adjectives, and the names just tell you what it is. The new system highlights there are two different diseases with distinct appearances, biopsy findings, immunohistochemistry patterns, treatments, prognosis, and outcomes.
Absolutely, that was the goal. So to summarize, if the etiologic agent is HPV, for neoplasia, we recommend HPV-VIN, although HSIL is appropriate in some settings. The key to diagnosis is a block-positive P16. And the terms for HPV-A lesions are already familiar to us, LSIL, like at the cervix, and condyloma. For HPV-I precursors, we recognize they arise in lichen sclerosis, and diagnosis requires a negative P16 and a supportive P53. We recommend the term HPV-VIN. This is the precursor to HPV-I squamous cell carcinoma. Verrucous VIN is the precursor to verrucous carcinoma, and this is a subtype of P53 wild-type HPV-VIN. For HPV-I lesions, we kept VAM because it's a great way for pathologists to express uncertainty and to signal to us to do something different in our treatment and surveillance.
Brilliant. Thanks so much. So if this is an unfamiliar topic for you, I'd encourage you to save the article and refer to the tables when reading your histopathology reports. And if you're already doing a lot of work, then liaise with a local pathologist to ensure that we're all talking the same language. Getting this right aids our efforts in vulval cancer elimination. You can access the resources discussed in today's episode in the show notes. If you enjoyed this episode, please rate, review, subscribe and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking O&G.